first to go on would be Dr. VINITA RAMNANI. She's a consultant ophthalmologist from Bansal Hospital, Bhopal, and she's a leading cataract and glaucoma surgeon, and she has a glaucoma cataract video to showcase at this point of time. On to you, Dr.
Thank you so much. At the outset, I would like to thank Chitra ma'am and ARC for giving me this opportunity. I will be presenting combined single-site phacotrabeculectomy, which is a double beetle with single weapon and coexisting glaucoma and cataract. We need it because many of our patients, they have glaucoma and cataract coexisting, and 10% will require a surgery. But we need to have factors like evaluation of the cataract and glaucoma, the comorbidity, the patient's preference and affordability, and even the surgeon choice and skill to go for the single-site phacotrabeculectomy. I will be giving 5 pearls. The first will be a effective preoperative evaluation. We should understand the type and the density of the cataract, the pupillary dilatation and zonular integrity, which is very important, and the detailed workup in glaucoma so that you can give the realistic expectations to the patient. In very severe glaucoma, we have to be careful about the wipeout. It is to be done in a patients where there is an IOP is uncontrolled and there is a significant cataract. The surgical techniques, thus anesthesia, most preferred is peribulbar, but many can do it in a topical also. The fornix-based conjunctival flap is one which to be chosen more in combined. And in season, either at 12 o'clock or steep axis, depending upon the individual surgeon's preference. The technique of the phaco remains the same as any cataract surgeon, but one should avoid multifocal and toric IOS. And we can use the metabolites. This is a video after making in conjunctival flap. You have to make a partial thickness, 3.5 into 4 triangular flap. And through this triangular flap, you have to complete the phaco. The phaco techniques remains the same, doing a capsulorhexis and that removing the nucleus remains the same. Only thing is in an angle closer glaucoma, there is a bulky cataract and the anterior chamber is shallow. So one has to be very careful to avoid PCR in such patients. And then you cut a window after putting an IOL. So this inner window is 1.5 into 2 millimeters. And then you do a broad iridectomy and put a suture, one at the apex with the 10 nylon. Depending upon the surgeon's preference, one can put only one suture, that's okay. But we can put 3 sutures also. And one of them could be releasable, and at the end you can put an angle anchoring suture. So it is to be done in any variety. And if you want an Palma lens to be inserted, just increase the base of the triangle up to 5.5 millimeter. One can use the mitomycin C also. So the Merosul sponges soaked into 0.02 or 0.04 milligram, 3 to 5 sponges, one below and above the scleral incision can be used, and then a thorough wash to be given once you remove the sponges. The rest of the techniques remains the same. One can use the Cali sponge also if it is required. We can extend the incision on either side of the triangle and put the sutures in a dense, hard brown cataract. It is good for any of the primary as well as secondary glaucomas like pseudoexfoliation, ICE syndrome, complicated cataract post-vitrectomy along with the glaucoma, traumatic cataract and glaucoma. But one has to be careful about the vitreous losses, and it requires a good post-operative management with a frequent use of steroid and frequent follow-up visit. And sometimes the astigmatism takes little time to get stabilized. So we have to address both the conditions, and it is very cost effective and requires a lesser rehabilitation time. But there is a risk of manipulation and inflammation and increased post-operative hyphema and endophthalmitis. So you have to be careful. And it is concluded that it is a safe and effective treatment in our scenario, especially where the poor patients come. So it eliminates both the diseases together and provides a satisfactory IOP control, which is comparable to 2 separate sites or 2 separate surgeries. Thank you so much. Thank you for giving me this opportunity.
Thanks a lot, Dr. Vinita. That was a nice brief teaching video. I have some questions. I don't know how many of y'all in the expert panel our focused glaucoma surgeons, but they are all very straightforward questions. I think Vinita, Meenakshi, or any of the expert panel could take these questions. How would you minimize conjunctival leaks after phaco trap, Dr. Vinita?
One has to be very careful that when you are passing a superior rectus suture, the bridal suture, you should not injure. It should be atraumatic. So one can use the corneal traction suture in place. And secondly, the conjunctiva should not be held with the tooth forceps. One can use the blunt forceps so that there would not be any injury through the forceps. Third, that tension should not be there on a conjunctiva. When you stitch the conjunctiva, it should be little loose. So you should expose the conjunctiva little larger. It should not be a smaller exposure with a tightening at the end so that it will create a tension.
And also it makes sense to include the tenons in the suture bite when you're taking the final closure, and also keeping the mitomycin well away from the edge of the conjunctival flap, and of course using a complete closure of this incision site, and also atraumatic needles would help. And anything to add, Dr. Meenakshi?
Yeah, one can use subconjunctival tissue to catch hold of the sclera and subconjunctiva so that it sticks to the sclera. It should not move forward.
One thing is that we can leave a small rim of conjunctiva when we are making our fornix-based conjunctival incision.
Yes.
The other thing is at the end of each surgery, I always do a Seidels test. So that we know that if there is any inadvertent leak, one should either way check the patency of your trab and see whether that is fine or not, and also check whether the bleb is forming, and also check if do a Seidels that it should not be leaking. And it's always better to do a corneal stay suture rather than the superior rectus. I personally prefer, and I feel even literature now sides up more with a two-site phaco trap rather than a single site, because the effect of the aim of a cataract section is that it should be properly sealed, and the aim of a trabeculectomy section is that it should be allow passage of allow filtration.
Now, the other relevant question is, this is a neovascular glaucoma which where trab has been done, right? So would GDD have been a better option? But again, when would you decide to do a trab in a neovascular glaucoma?
Is that to me or to Vinita?
Yes, Dr. Vinita.
See, if it is a known case of a diabetic retinopathy or CRVO where the IOP is not that high, and if you have controlled the ischemia factors very well by giving anti-VEGF and doing a good PRP, I think then IOP you can very well control with mitomycin C trab. But then the results are different in different hands. Some people, they prefer valve first in comparison to trab, and I always try trab first, and if it fails, I have an option open for AGV next time.
Yeah, but only thing is, as you said, if the neovascularization has regressed, a trial may not be a wrong idea, but you can augment it. The neovascular glaucoma needs a very tighter IOP control. So you could do things like placing a mitomycin pledget under the scleral flap too, instead of just placing it above. And you could also make a small gutter in the scleral bed. Or the third option would also be that you could even do a cyclodialysis augmented trap. When you do all of these, you get a very low single teens intraocular pressure control, and that's very good. I think we would move on to our next speaker. Thank you very much, Dr.
Thank you, ma'am. Thank you. Thanks, and thank you, madam, taking my case as a first case. Thank you, ARC, for the